Hi, good evening, everyone. So let us start with this session of Fast Track Revision Series 4. So before I start, let me tell you about the iconic subscription where you get Unacademy and Preparator together. And we have a lot of features in the special classes. So do make use of them. Yeah. Okay. So come on, let us start with this. The first question that we are going to start with is most common type. So most common type of esophageal atresia. Yeah. Most common type of tracheoesophageal fistula that we have. Come on, answer B. Most common type of tracheoesophageal fistula. Yeah. A, B, C, or D. Come on, A, B, C, or D. Hi, Shiv. Hi. I thought that I have rescheduled the class. No one will come to my class, but happy to see so many of you taking the live class. Yeah. Okay, great. So yes, very good. It's esophageal atresia with a distal segment involved. Yeah. A is the right answer. A is the right answer. Let us try to have a rapid revision on this. Yeah, let us try to have a rapid revision on this. So when we talk about the tracheoesophageal fistula or esophageal atresia and tracheoesophageal fistula, let us quickly discuss the types. If you see the order, it is A, B, C, D, E. But if we see the order according to the incidence, it is C more than A, more than E, more than B, more than D. So remember, D is the least common. Yeah. Today we are going to. Okay. Shiv, it's not possible to cover up everything in this small short session, but still I try to cover a lot of things. So today we are going to discuss something on tracheoesophageal fistula, esophageal atresias, and then we'll see many other topics also. Yeah. So let us try to understand this. Just a minute. Okay. So when we talk about type A, what is type A? This is pure esophageal atresia. This is a pure esophageal atresia with no TEF. So this is the trachea, this is the esophagus. This is type A. This is a pure atresia. What is a type B? It's a proximal TEF. So the esophagus is fused proximally with the what? Trachea. So this is what is a proximal TEF. Proximal TEF. Then we have type C. What is type C, students? What is type C? It is the proximal segment atretic is blind, but the distal atretic segment is having the fistulous connection with the what? With the trachea. So this is trachea, this is esophagus, this is what is known as a distal TEF. Distal TEF. Then we have type D. What is type D? It's a combination of a proximal and a distal TEF. So if you see here, we have both. So proximal plus distal TEF. And what is the type H? This is a TEF without atresia. Can you see in all of them there is atresia? But here the esophagus is also normal. The trachea is also normal. But yes, there is a connection in between them. So there is a connection in between them. We say this is the atresia is not there. It is a pure TEF. It's a pure TEF. And that is the reason it is also known as H type. It is also known as H type. Let us try to quickly understand the most common presentation. So when we talk about the presentation of TEF, what is the classical presentation? But the newborn will not be able to take in the saliva, basically. So what's the classical presentation? Answer is excessive drooling of saliva. This is very important. Excessive drooling of saliva. Along with this excessive drooling of saliva, what else do you get to see, students? Yeah, you get to see sudden onset of choking, on food intake. So sudden onset of cough plus choking on food intake. So why this happens? Can you understand why? Because of the aspiration, all these symptoms. Yeah. Okay, great, Tavish. So sudden onset of cough and choking on food intake, and then students, the baby cries, the baby will cry, and crying with worsening of respiratory distress, Now why this happens? Try to understand one very simple thing. I'll not go into too much of depth of this, but the most common type is a what? Is a type C. Now this is a trachea. When you are feeding the baby, the food is going like this. The saliva is going into, or the food is going into the trachea. So from the esophagus, it goes into the trachea, and therefore violent onset of cough and choking. Now because there is violent onset of cough and choking, the baby will cry. When the baby cries, the problem is that the air is pushed into this. So the air is pushed into the stomach, and when air is pushed into the stomach, what will happen? It will push the diaphragm up. So there is distension of the stomach, and when there is distension of the stomach, it will push the diaphragm up, and if it pushes the diaphragm up, but the respiratory movements will be a bit jeopardized. Is that clear? So distension will actually reduce the diaphragm movements, So these are very, very, very important things that we all have to understand. Then you should be knowing, or you must be knowing, that majority of them are associated with what? A group of disorders which are known as vectorial group of disorders. I'm not going to that. Let us quickly discuss the treatment part in nutshell, because since this is a rapid fast track revision, so I'll just revise the important part. But when you are considering the management, what are the two most important things? But birth weight, one is birth weight, and second is cardiac anomaly. In fact, the most important prognostic factor is your cardiac anomaly. So cardiac anomalies, presence or absence of cardiac anomaly will change a lot of things. Let us see. But there are two criteria. The older criteria that we were using, what was Waterston. But students, now we are not using that. What we are using nowadays, we are using a modified Spitz criteria. What is a modified Spitz criteria, students? In this, you are going to see a lot of things. What are you going to see? The first thing that you see is the birth weight. What else do you see here? Come on. You see the presence or absence of what? Cardiac anomaly. So presence or absence of cardiac anomaly. So birth weight, presence or absence of cardiac anomaly. The third thing that you are going to see here, what is that? Yes, the percentage survival, and based upon this you also discuss the management. So let me discuss it for you. But the scenario number one could be a condition where the birth weight is more than 1.5 kg, or there is no cardiac anomaly. Yeah, so birth weight is more than 1.5 kg and no cardiac anomaly. Yes, and then what is the percentage survival? More than 97% survival. So let us talk about this. This is the survival rate. And then what is the management? Come on, what should be the management? Yes, the management is definite surgery. We will see what is the definite surgery. But if the birth weight is less than 1.5 kg, yeah, or there is presence of cardiac anomaly, but less than 57% survival, and here again seeing the benefit more than the loss, you're going to go for definite surgery. बच्चे, if the birth weight is less than 1.5 kg plus there is a cardiac anomaly, less than 27% chance of survival, and therefore you will wait for the patient's maturity to withstand that surgery. You know, cardiac status is too weak. The body's birth weight is too low to sustain the effect of general anesthesia. So, bache, for them, you will first go for feeding gastrostomy. So, feeding gastrostomy is what is the call, and this is what is the modified Spitz criteria. Bache, you also know that what is the definite surgery? The definite surgery is excision of TEF, excision of the fistula of TEF, and along with that esophagostomy. नहीं बच्चे देखो, yeah, it's the criteria is bit different. देखो Shiv, try to understand here, less than 1.5 kg. देखो earlier it was 2.5 to 1.5, अब वो सब हट गया. All those things are gone now. Less than 1.5 with cardiac anomaly, or either the weight is less, but yeah, so birth weight is, it's very important. So if birth weight is less than 1.5 and there is no cardiac anomaly, yeah, if there is or if there is a basically a cardiac anomaly less than 57%, but here both should be present, either of them or both. This is how we are seeing. So let us go to the next question. We are going to the next question. Yeah. Okay. Chalo. All except are the content of triangle of Doom. All except are content of triangle of Doom. Come on, tell me. Bache, Waterston criteria is no more used. Sukhbir, have I taught you? Bache, Waterston criteria, देखो, that's an age-old criteria. अब नहीं use करते. Nowadays, the pediatric anesthesia is advanced. Waterston criteria was taking in accordance of pneumonia, etc. Also, that time pediatric ventilators were not there. Nowadays, bache, the things have changed. Lot more advanced things. So, answer me this question. All except are contents of triangle of Doom. What is not? This is not. Lateral cutaneous. Yeah, lateral cutaneous femoral nerve. So, lateral cutaneous femoral nerve is not. Lateral cutaneous femoral nerve. This is not. Let us try to understand this. This is again very simple. Let us talk about the concept of triangle of Doom, triangle of pain. Triangles of laparoscopic surgery. So triangles of laparoscopic hernia repair. They are very simple, very simple in fact. So now many of you make mnemonic, you mug up, but there is no point. It's very easy. But have you seen a surgeon mugging up anatomy and entering the surgery, entering the operation theater? Today I'll cut first the rectus and then the skin. No. It was skin, then the rectus. No. First I will cut the peritoneum, then I'll get the rectus, and then I'll go inside, and then I will first cut the gallbladder, then I'll clip it. No. First I'll clip it. So don't mug up. So try to understand. It's very simple. सबसे पहले develop the orientation. The first thing, if you want to understand them, develop the orientation. Where are you? सबसे पहले तो यही पता होना चाहिए, where are you? So बच्चे, take this to be inguinal canal. Yeah, imagine this to be what? Inguinal canal. Yeah, so this is inguinal canal. So this is roof, this is the anterior wall, this is the floor, and this is the posterior wall. I hope you know the posterior wall is made up of what? Yes, transversus abdominis and fascia transversalis. Yeah, transversus abdominis plus fascia transversalis. So actually you are seeing the fascia transversalis, which is having the deep ring, the hole which is known as deep ring. The next, the cavity behind that, What is that cavity behind? This is the abdominal cavity. Yeah. So when you will come for training to my institute, I actually emphasize on this anatomy, because bache, in laparoscopic surgery, if you don't know these anatomies, you'll always commit errors. So all the residents who come for the training, I always emphasize on the basics of anatomy, and this is very, very, very important. Yeah. So try to see this. Try to see this. Bache, this is the peritoneum. This is the peritoneum. So what cavity are we looking at? We are looking at, imagine we are looking at this cavity. Yeah. I hope this is clear. So this is your camera, telescope, blah, blah, blah. You are inside. But you get across these triangles in laparoscopic repair. The question number 1 is, where are you in the laparoscopic repairs? But we are in a avascular space. And what is that avascular space? Can you tell me what is this avascular space? So this is a pre-peritoneal space. Whatever mesh you place in the pre-peritoneal space. Students, once you develop the orientation, you will never be at loss. So pre-peritoneal space, or this is also known as space of what, students? Bogros. Space of Bogros. So actually, if this is the mesh, where am I going to place this mesh? Where am I going to place this mesh? I'm going to place this mesh here. Are you getting? Where? In the pre-peritoneal space of Bogros. So one thing is clear, that in front, the screen that you are seeing, this is the fascia. The white background that you are seeing, this is the peritoneum. So I am sitting in the pre-peritoneal space of Bogros. So now let us try to develop that orientation. Just see, students. But see, what is this? Imagine this to be what? Fascia transversalis. What is this? This is deep ring. You know, I know, everyone knows that who is forming the base of the fascia base of the, you can say, deep ring. So the lower end of the fascia transversalis is rolled upon itself to form something which is known as iliopubic tract. So this is known as iliopubic tract. Are you getting this? Iliopubic tract. Now, who is entering the canal from the medial side? Tell me, who is entering the canal from the medial side? Answer is, sir, it is vas. Vas is going to enter the canal from the medial side. Yeah. Now, who is going to enter the canal from the lateral side? Yeah. So it is the gonadal vessels. It is the gonadal vessels. Are you getting this or no? So these are the gonadal vessels. So who is present laterally? Gonadal vessels. But you like it or you don't like it, in front is fascia. So behind the boundary will be made by whom? What is this? What will be here present? Yes, it will be peritoneum. Peritoneum. Can you appreciate one triangle here? Yeah. Can you appreciate one triangle? What is this triangle known as? This is known as triangle of doom. Triangle of doom. Again, try to appreciate one more thing. But in front is fascia. Behind will be what, students? Behind will be what? Peritoneum. Peritoneum. So can you see one more triangle here? Can you see one more triangle here? What is this triangle known as? Triangle of pain. Triangle of pain. So triangle of doom, triangle of pain. Triangle of doom, triangle of pain. Again, those who haven't understood, never mug up. What is this ring? Deep ring. What is this? Deep ring. Yes. Who is forming the base of the deep ring? Iliopubic tract. Can you see? Can you appreciate iliopubic tract? Who is going into the canal from the medial side? Who is entering the canal? Answer is vas. Who is entering the canal from the lateral side? Yeah. Who is entering the canal from the lateral side? Answer is the gonadal vessels. Gonadal vessels. Are you getting this? So this is vas. This is gonadal vessels. Try to understand who is present behind. Who is present behind? Let's say peritoneum. Peritoneum. Can you see triangle of pain, triangle of doom? So don't mug up them. But it's a bread and butter for us. If you don't understand this, we'll do a catastrophic injury. And can you see together a trapezoid? A trapezoid of disaster. Trapezoid of disaster. When we talk about trapezoid of disaster, who is forming the medial part of this trapezoid, students? Answer is the triangle of doom. Triangle of doom, triangle of pain. This is why. But why it is known as triangle of doom? Why it is known as triangle of pain? So pain is forming the lateral border. The answer is because of the exclusive content. What is the content of this? Come on, tell me. What is the content of this? Why it is known as triangle of doom? Because it contains the external iliac vessels. It contains external iliac vessels. Along with that, you get to see genitofemoral nerve. What branch, students? Genital branch. Plus minus there may be femoral nerve. But see, what about the triangle of pain, students? What about the triangle of pain? It contains the femoral nerve, LCFN, lateral cutaneous femoral nerve. Actually, this is the most common nerve injury during laparoscopic surgery. And then we have genitofemoral nerve. What branch, students? Femoral branch. These are very important. Now, do you know what is the concept? And if you have attended my lectures, I always show them in my videos. I don't ask you to mug up because you have to understand, and then you'll feel better about this topic. You'll have more confidence. Do you know if you do any dissection in this triangle, you will cause a catastrophic damage to the artery? And what is the biggest challenge in any laparoscopic surgery? Answer is the hemostasis. So vascular controls really are very difficult, and if you're damaging external iliac, bache, you should run out of the OT because you'll not be able to stop it now. Patient is going to die. It's a triangle of doom for both patient and for the consultant. रिश्तेदार क्या करने वाले हैं OT का, आपके hospital का, you know. Yeah. But when you talk about the triangle of pain, why it is known as triangle of pain, try to understand. In order to secure a hernia, you have to put a mesh, isn't it? You will have to put a mesh. So this is a mesh. You have put a mesh. In order to secure a mesh, you put tackers, or you may put the sutures. Generally, we put 2-3. I don't prefer to use more than 2-3 tackers. Those are 2 or 3, not more than that. But if you go and put the tackers here, what is the problem? The problem is that this is an area which is having a rich network of what, students? Nerves. So you have actually sutured a nerve. So no tackers. Important is no tackers placed below iliopubic tract. Why? Because if you entrap the nerve, what will happen? So there will be nerve entrapment. You keep on giving painkillers to the patient for years to come. This will not get removed. That is why you must have seen many people say, डॉक्टर साहब वो ओपन वाली कर देना, मेरे रिश्तेदार ने कराई थी, वो बड़े बढ़िया डॉक्टर थे, लेकिन फिर भी बहुत दर्द होता है. This is the reason, and that is what is known as CPPS, chronic pelvic pain syndrome. So बच्चे, nerve entrapment is the biggest risk. So if you come to that question, just see. So what is not a content of triangle of doom? External iliac vessels, yes. Femoral nerve, yes. Maybe deep circumflex iliac vessels, yes. Lateral cutaneous femoral nerve is not. Chalo. Answer me this question now. All except are indication for thoracotomy in hemothorax. All except are indication for thoracotomy in hemothorax. Come on, students, tell me. No one? So initial chest drain output more than 1000 cc in penetrating injury. All except. Very good, Shiv. Very good, Zul. Very good. Let us talk about this. Maybe you'll have the exam in the month of March. Maybe still waiting for the final confirmation. But now no one can tell. Again, this Omicron, Delmicron, this and that. virus. No one can tell anything. बच्चे मतलब lucky are the people who have actually given the previous exam and have got a seat, but still they are unfortunate because still counseling is on the hold. So let us talk about this indication for thoracotomy in hemothorax. What is the concept of hemothorax? What is the concept of hemothorax? Let us try to see this. So when we talk about hemothorax, what is important about hemothorax? This is blood in thoracic cage, blood in thoracic cavity. This is what is known as hemothorax. Simple. Bache, what is massive hemothorax then? This is very important. What is massive hemothorax? Simple, very simple. More than 1500 ml, more than 1500 ml blood in case of adults, into the thoracic cavity, or in case of kids, more than 25% blood volume. So more than 25% blood volume in case of kids into the thoracic cavity. This is what is known as massive hemothorax. Bachcho, what is the treatment of hemothorax? Now this is important. If you talk about the treatment of hemothorax, this is same as the treatment of pneumothorax, and that is what is tube thoracostomy. Just put a tube, allow the blood to come out. So tube thoracostomy. And where do we do this tube thoracostomy? This is done at fifth intercostal space via triangle of safety. Fifth intercostal space via triangle of safety. I hope you know the boundaries of triangle of safety. Yes. Pectoralis, mid-clavicular line, mid-axillary line, and then horizontal imaginary line from this mid-axillary line towards the nipple areola complex. But now there are certain instances when you cannot manage the patient with tube thoracostomy. So let us try to understand that also. What are the indications? Of thoracotomy? What do you mean by thoracotomy? Opening up of thorax. The first indication is in case of massive hemothorax. Point number 1. Suppose bache, you got a patient of thoracic injury, suspected hemothorax, and you did a tube thoracostomy. The amount of the fluid which comes out is very important. What is that known as? Initial drain output. So students, initial drain output, yeah, more than 1000 ml in case of penetrating injury, yeah, or more than 1500 ml in case of blunt injury, yeah. But obviously it is qualifying for what? Yes, a massive hemothorax. So more than 1000 ml in penetrating injury means something vital has been damaged. Yeah. The third is, so massive hemothorax, initial drain output more than 1000 ml in case of penetrating injury, or more than 1500 in case of blunt injury. The third is, suppose you did a tube thoracostomy and only 250 cc came out. What to do? You'll wait for 1 hour. Next hour, suppose again 200 ml was added extra to the pre-existing volume. So bache, if for 3 consecutive hours the output stays more than 200 ml per hour, that means that something vital is bleeding, boss, and this is the time to take a call, because God has already taken a call for this patient. So what is that? The tube drain output more than 200 ml per hour, for at least 3 consecutive hours. For at least 3 consecutive hours. The fourth is a scenario which is known as a caked hemothorax. What do you mean by caked hemothorax? What do you mean by caked hemothorax? Answer is, बच्चे, a clotted hemothorax. A caked hemothorax is a clotted hemothorax. So if the hemothorax is clotted, if it is a clotted, yes, then you should be avoiding this. So if you read the question, all except are indications for thoracotomy in hemothorax. The initial chest drain output more than 1000 cc is significant, but in case of penetrating injury, it becomes more significant. You have to wait. You have to go for surgery. You don't have to wait. You can say you have to go for thoracotomy in form of surgery. Massive hemothorax, yes. Caked hemothorax, yes. More than 100 ml per hour for more than 2 consecutive hours, no. More than 200 ml per hour for 3 or more consecutive hours. So this is wrong. This is wrong. Chalo. Answer me this question. Come on, answer me. All except are true for Ecclesia. Pressurization of esophagus, high amplitude waveforms, failure of LEX to relax, and simultaneous mirrored contraction. Tell me something about Ecclesia. Come on, tell me. All except are true. I'm talking about. Shovik, try to understand. All except are true. B is the right answer. Anyways, I'll help you understand first. Why D? बच्चे D happens. D तो होता ही है. Lot of you are confused. D will always happen. D will always happen. Yeah. Only Priya has answered right. Sorry. In fact, no one. Let us try to understand the concept of this. This is a very easy thing. When you talk about Ecclesia students, let us try to understand the concept of Ecclesia. No. I'll explain this. So let us talk about Ecclesia. What happens in Ecclesia? So let us see a normal esophagus. Let us talk something. Bache, for relaxation of the esophagus, we have something which is known as Manometry and Meissner's plexus. So Manometry plus Meissner's plexus. So Manometry and Meissner's plexus are responsible for the relaxation. The second very important thing is, for relaxation, we have nitrous oxide synthetase, and the basic area where they are concentrated is around the G junction. Yeah. So NOS stands for nitrous oxide synthetase. So we have two factors which are going to be responsible or pivotal for relaxation. Or which nitrous oxide synthetase is going to produce what? Nitrous oxide. And nitrous oxide is going to cause relaxation. Well, yeah. So this is very simple. I'm trying to build up this concept. But then what are the factors which are responsible for constriction? So for constriction, we have something which is known as what? Acetylcholine. So acetylcholine is responsible for constriction of the lumen. Constriction. Now, do you know what is Ecclesia? Ecclesia is a Latin term which means failure to relax. And why this happens? You must have studied this, that Ecclesia is defined as progressive loss of myometric plus what plexus, students? Meissner's plexus. Yeah. Oh, okay. So progressive loss of Manometry plus Meissner's plexus. Now what happens? The game is, just see. Bache, esophagus is saying, okay, I accept this, but nitrous oxide is there. The second problem which happens here is there is also a non-functional nitrous oxide synthetase. So a non-functional nitrous oxide synthetase. So do you know that since this is gone, if Manometry plexus, if this is gone, oh, okay, if this is gone, if nitrous oxide is gone, then there is no one is to counter this activity, and thus therefore there is uncontrolled plus unopposed action of acetylcholine. Are you people getting this? This is a very simple thing. And because of this, what will happen? Just see, bache. The first thing is on manometry. On manometry, what are you going to get? Try to understand this. Bache, first of all, there will be increased tone at the LES. There is increased tone of LES, and not only there is increased tone of LES, this is going to fail to relax. And why this is happening? You know, I know, everyone knows that this is because of the acetylcholine which is acting. Since it is progressive and it is starting from the lower end, that is why you get to see typical tapering towards the lower end on barium, and that is why that bird beak appearance. So increased tone of the LES, point number one. The second point is failure to relax. But because of this, the another things that we get to see. So ये होता है LES के level पे. What happens at the body of esophagus? Body of esophagus, first of all, you get to see a peristalsis. You get to see a peristalsis. But why you get a peristalsis? Because of the low amplitude waveforms. Low amplitude waves. So low amplitude waveforms. Thus, third is, bache, if you see in the late stages, complete esophagus will be compressed by the uncoordinated, unopposed action of the acetylcholine, and this is what is known as the pressurization of esophagus. Do you know one very important thing, that how a peristaltic wave happens? But this is how a normal peristalsis is there. Can you see the both the walls are complementary. So both walls, if they are complementary to each other, bache, peristalsis will happen. Try to understand. If this is a bolus of the food, it will slide around easily. No problem. Why? Because if you see there is elevation on this side, there will be depression on this side, elevation. So bache, this kind is a progressive peristalsis. This is what is progressive peristalsis. What happens in Ecclesia? Dekhte jao. Bache, first of all, the peristalsis is absent. A dying esophagus tries to generate the high amplitude waves also. It tries to, you must have heard of vigorous Ecclesia, distal spastic contraction. So in the early dying stage of the esophagus generates powerful high amplitude contraction, but they all are in vain, because if you see the peristalsis is exactly the mirror image of each other. So आप मेरे को ये बताओ कि how will this bolus go down? It will not go down, and this is what is known as simultaneous mirrored contraction. So in vigorous Ecclesia or type 3 Ecclesia, so simultaneous mirrored contractions happen. Simultaneous mirrored contractions do happen, and bache, therefore they are non-progressive. So in Ecclesia, first of all, it is not present. If it is present, it is non-progressive. So progressive versus non-progressive, we have seen this. and in Ecclesia you get to see this. Ecclesia you get to see this. But today Ecclesia is not diagnosed by the classical triad of regurgitation, reflux and weight loss, nocturnal regurgitation. Today if you want to confirm a diagnosis of Ecclesia, you have to have these points. But this is what is a manometric criteria for diagnosis. Ecclesia is not a diagnosis on barium, it is a manometric diagnosis. Are you getting this or no? If these 5 points are present, you cannot make any diagnosis other than this. So if you see pressurization of the esophagus, absolutely true. High amplitude waveforms, absolutely true. Yes, because they may be, may not be. Yeah, they may be, may not be. Failure of LES to relax, absolutely true. Simultaneous mirrored contraction, absolutely true. Bache, try to understand. Out of them, this becomes the answer of exclusion. Why? Because not all of them will have the high amplitude waveforms. So bache, the answer of exclusion is B. Are you getting this or no, bachcho? Are you getting this? So answer of exclusion is B. This is art of solving MCQ, because all the options might be correct at a time, but it is your smartness. You will have to decide kise mark karna hai, kise nahi karna. I hope that's clear to everyone. Yeah. Okay. Let us talk about this blend mode 3 of monopolar electrosurgery. Blend mode 3. So let us talk about this blend mode also. Blend mode 3, bata do bachche. It's very easy. So blend mode 3. Let us talk about the monopolar electrosurgical unit. So if we talk about monopolar ESU, if you talk about monopolar ESU, how is this different? Let us try to understand. The current is going to flow into the body. This is the patient electrode. This is the you can say surgeon's electrode, and then it is going into the body, and from body you attach a patient plate. And this patient plate is quickly going to gather the current and returned it back to the machine. So bache, one electrode is in hand of surgeon and one electrode is attached to the body of the patient, and you know the current. If you see this is a pointed electrode, so that the current has to face. So important is the patient electrode is broad, but the surgeon's electrode is, you can say, narrow. Why it is narrow? So that you can have the steric hindrance, and when there is steric hindrance, this is going to generate heat. So this is going to generate heat, and this heat is going to produce that cut and the seal phenomena. Let us try to understand this. Bache, when we talk about the monopolar electrosurgical unit, there are two modes here. What are the two modes? Let us try to understand. So monopolar has two modes. What are they? Let us see. First is the cut, the another one is a seal. Bache, what color code is being represented by them? What color code is being represented by them? Cut is yellow, seal is blue. So cut is yellow, seal is blue. Let us try to understand them. Yeah. The first very important thing is, what is the current kinetics? Yeah, let us see. When you talk about the voltage and the frequency, let us try to understand this. Okay, so voltage is low for cut, and current frequency is high. Similarly, the voltage for seal is high and the current frequency is what? Low. But how is this going to be different? Try to understand. Now suppose this is the tissue, and on this tissue, if you are going to touch it with a what? Cut. So the current is flowing in a high oscillations but in low voltage. Due to high oscillation, there is rapid turbulence. So due to increased frequency of the current, yeah, there is a rapid turbulence. But because of this turbulence, so rapid oscillations, because of rapid oscillation, there is turbulence. Because of turbulence, there is collision, and because of the collision, there is generation of the steam, and generation of steam. Yeah. Laparoscopic word provides courses after MBBS is good or bad? We don't want to study NEET PG. Oh, travel. We have lot of courses on in laparoscopic word for this MBBS courses. Don't worry, they're very good. If you don't want to do PG, at least I can make you competent enough to be a very good doctor. At least be confident in majority of the basic surgical procedures, and we at our institute give you a good you can say exposure to the laparoscopic surgeries also. Yeah, you get to see a variety of surgeries, not only laparoscopic and advanced colorectal, advanced surgeries, everything. So to that you will have to come and experience that. Yeah. Anyways, so let us do this. So generation of the steam, and if there is generation of the steam, what will happen? Steam will expand. The steam will expand, and when it expands, the tissue will blast. You can go to my website www.drsaurabhdixit.com. Go to the training section. You'll get a lot of information, or you can come to the center to experience that. So the tissue will blast. Actually the cut is like blasting of tissue. It's a bomb blast. Yeah, it's a bomb blast. So try to understand, pure cut is not needed, but a cut should be minimally used. So if you talk about the pure cut, what is that? 100% on cycle. So if you are pressing the button for 3 seconds, it is blasting the tissues. This is what. So this is pure cut. Then we have a blend mode. If you talk about a blend mode, so in order to minimize the tissue damage, yes, we have blend 1. What is blend 1? 50% on, and 50% off. Yeah, 50% off. Now try to understand, what is blend 2? It is 40% on and 60% off. But this is the time of apocalypse. No one knows what is going to happen. No one knows. So this is the best time. Whatever you want to learn, whatever skill you want to acquire, kar lo abhi. No one knows what is going to happen. So what is blend mode 3? 25% on, and 75% off. So if you see this question, the answer is there. Yeah. Shiv, you come to my institute for few days, you will get relaxed, or whosoever is feeling tension, come to my institute, learn some surgery, and you will be really very happy. Bhul jaoge sari tensions, at least. You'll start your surgical training. Jab bhi hoga, you'll get it. Then the degree zone, then the only thing that you need is a degree after that. So next is, when you talk about seal, what is the difference in seal and cut? In seal, we have high voltage and low frequency. So high voltage is going to cause melting of collagen. This is causing melting of collagen. Yeah. And when we talk about melting of collagen, what is going to happen? By the time the melted collagen could have converted itself into steam, could have converted itself into steam. It is gone. It is gone. The current is gone because of the low frequency of current. You cannot have that steam generation here. So it cools, it solidifies, and now it becomes what? A scar. But if you reheat Shiv, then only it will become a what? A charcoal, and it will get dislodged off. Is that clear? So this is what is the concept of scarring. But do you know this is only 6% on, and 94% off. 94% off. So let us try to understand this. If you enjoyed this session, do join Unacademy, and please don't forget to use the code Dr. Dixit. Yes, staff. Hi, how are you, staff? Yeah. So do join Unacademy. Do follow me on Unacademy so that you don't miss notification of my class. Yeah. You're most welcome. Travel. You're most welcome. You can come for a day or two. You can experience the hands-on. It's free of cost. We offer a 24. 24 hours. I'm saying 2 days free hands-on course. Also, you can come. You can enjoy. You will learn. If you feel like, then take admission. So I hope that you people enjoyed this session. We'll be coming with more such interesting sessions, and we'll be just meeting again. So till then, bye bye. So travel, waiting to meet you in Delhi. You can come. All the information about the training is there on the, you can say, website. Till then, bye bye.